So here we are in chapter 7 of disease process, which is the musculoskeletal system. These are the topics we are going to be learning today. So if you see a disease or condition in the book that isn't one of these, don't worry about them. These are the ones we're going to focus on. All right, to start things off, let us go over the anatomy of the musculoskeletal system. So first, we're going to talk about the bones. The bones are what provide the structural support for the body. The skeleton provides the frame. What is bone? Bone is a specialized connective tissue. It's obviously a lot harder than most other connective tissue. What makes it hard, that stiff material that is able to provide the support, is calcium and phosphorus, two minerals that are necessary for bone hardness, which we all know for watching all those milk commercials. Milk causes strong bones because of calcium. Calcium and phosphorus, however, cannot be absorbed by the body into the bones without also having adequate levels of vitamin D. So just taking calcium supplements or drinking milk isn't necessarily going to strengthen your bones unless you are also taking a vitamin D supplement or getting enough sunlight. Most Americans actually have vitamin D deficiencies because of our lifestyles. We're inside most of the time, inside the house, having office jobs. We aren't outside in the farms, like we used to be back before, the industrial age. So, unfortunately, a lot of us are vitamin D deficient. There are two hormones, which should be a review from chapter 4 when we did the endocrine system: calcitonin and parathyroid hormone. These two work opposite, so they have different and opposite effects in order to keep calcium levels in a optimum level within the bloodstream. So they work together to provide homeostasis. Parathyroid hormone lowers the calcium levels in the blood. Take that back. Calcitonin works by lowering the calcium levels in the blood and moving the calcium into the bones to make the bones stronger. Parathyroid hormone does the opposite. When the calcium levels are not high enough, so they're too low in the bloodstream, they fix that by taking calcium out of the bones where it's stored and bringing it into the bloodstream to help keep the optimum levels. So too much parathyroid hormone activity can actually weaken bones over time because they're constantly taking calcium from the bones, whereas calcitonin actually helps to strengthen the bones by putting extra calcium there. All right, so there are 3 types of bone cells. They are osteoblasts, osteocytes, and osteoclasts. Okay, osteoblasts, these are the cells that actually help to build bone material. So our bones don't just stay the same until we die, right? They're constantly being broken down and remodeled and fixed up, kind of like how our nails and hair are always growing. Our bones are constantly being remade as well. So the osteoblasts are responsible for building the bone. I remember that because of the B, osteoblast, B for build, bone builders. Osteoclasts, these are what break down old bone cells that just need to be tossed out to bring in the new bone cells. And I remember that because of the C, osteoclasts, I think C for crush, like crushing and breaking down the old bone. And then an osteocyte is just what we call a mature bone cell. Once the osteoblast has produced it, it's just a bone cell itself is an osteocyte. So now we have the impacts of exercise. So exercise and weight-bearing activities like lifting weights, going to the gym, these actually promote osteoblast activity. It's like telling your body, like, hey, our body is constantly going under this additional stress or tearing something. We need to strengthen ourselves to withstand this extra pressure. So the osteoblasts start producing more to make the bone stronger. Whereas if someone is, inactive, has a sedentary lifestyle, that tells the body, hey, we don't really actually use our bones for that much, so we probably don't need to focus on keeping them strong. So they're not really a priority right now. So the osteoclasts will start breaking them down, using the calcium for something else. It's kind of like the mentality, use it or lose it. All right, and this is just a little diagram of what the bone looks like. So at the ends of the bones, we have spongy bone. It's kind of like this porous material, whereas like the shaft of the bone is compact bone, so it's really stiff, to less likely to fracture. The bone marrow is in the center. That's where the all of the blood cells are made, red blood cells, white blood cells, all that stuff is formed in the bone marrow. That's called, the process of creating blood cells is called hematopoiesis. Then you see there's blood vessels, so like there's even blood vessels that go to the bone. And then there's that little line right here called the epiphyseal line, or sometimes called the epiphyseal plate. This is also known as the growth plate. So if you recall from chapter 4 in the endocrine system, we talked about gigantism and acromegaly, conditions where too much growth hormone is being released into the system, and how if it's released before puberty, it leads to gigantism, and if that growth hormone is released too much after puberty, it leads to acromegaly, and it has to do with this epiphyseal plate. So these are the growth plates. You might have heard of like, oh, their growth plates are open, their growth plates are closed. As long as the growth plate is open, like height is still able to, you're still able to grow in height. But once the growth plate is closed, then like you're not really going to grow much taller after that. So that's what that is, that epiphyseal line found commonly in like the leg bones. All right, and just a quick overview of some muscle. We talked about cardiac muscle in the circulatory chapter. Smooth muscle is the muscle that lines the digestive system, which we talked about last unit. And skeletal muscle is just like the voluntary muscles of like your leg, and your arms, something you have voluntary control over. Smooth muscle and cardiac muscle are involuntary, right? You don't have to tell your heart to beat, it does it by itself. You don't have to tell your intestines to digest and to do the action of peristalsis, which is the rhythmic moving of food out of the body. So we're going to be focusing on the skeletal system, musculoskeletal system today. All right, so our first condition, let me get a drink of water real quick. Our first condition is fibromyalgia, which is a chronic pain condition, mostly affecting the nerves, but you feel it like in your joints, your bones, in your muscles. So it's technically like a nerve firing disorder, but the nerves and the muscles, those are all connected. Hence the neuromuscular junction where signals are fired off of. Symptoms of fibromyalgia is just constant pain, which can lead to fatigue. Like if you're hurting all the time, you just eventually just get worn down. Diffuse aching, diffuse just means kind of spread out. Stiffness of muscles and joints, so much so that it can disturb your sleep and ultimately cause depression, just, from having this chronic pain disorder. Etiology is unknown. We don't really understand why this happens. But patients tend to experience pain from a stimuli that shouldn't cause pain. Like, for example, gently stroking someone on the cheek or on the leg would elicit a pain response in someone with fibromyalgia, whereas to someone else that would be maybe even comforting or just nothing. You wouldn't feel much of it. But something gentle or something that other people would interpret differently, they tend to experience subjectively as pain. They've also found that people with fibromyalgia tend to have lower levels of serotonin. And serotonin is a neurotransmitter or a brain chemical that affects mood, so it's very important with depression, and also affects the nerves. So that's part theory as to maybe why people have fibromyalgia. Diagnostic-wise, there's not really a test that exists to diagnose fibromyalgia. There's not like you can have a blood test or an x-ray and be like, yep, you have fibromyalgia. It's a purely subjective experience of the patient. There's not like a test or a meter that can determine how much pain someone's feeling. It's just a subjective thing. So any testing that is done is just to exclude any other conditions that exist. Okay, so like you might think, oh, maybe they're feeling pain because they have a pinched nerve or a bulging disc, or maybe they're feeling pain because they have bone cancer or whatever. So any test would just be to rule out any other conditions. In order to qualify for fibromyalgia, you must have this chronic pain and other symptoms like fatigue and depression as well. Unfortunately, there is no cure for this, mostly because we don't really know what's causing it. So you can't really cure it if you don't know what the cause is to address that. So the goal really is just to alleviate symptoms as best as possible. Antidepressants can be given to help both mood and sleep. Amitriptyline is an example of an antidepressant that's given. Anticonvulsants, this drug class should be a review from when we did neuro. Anticonvulsants are given to prevent seizures, but not only that, they also help calm down nerves in general, right? So like seizures are caused by spastic nerve firing, which can also cause pain as well. So the nerves firing off inappropriately, anticonvulsants will help calm down those nerves as well. And pregabalin is an example. Then also just your generic NSAIDs, non-steroidal anti-inflammatory drugs. These are just your standard like ibuprofen, Advil, Motrin, aspirin type of things to help with mild pain. All right, so now spinal disorders. There are 3 different types, and we're just going to quickly go over those. There's lordosis, kyphosis, and scoliosis. So let's start with lordosis. This one is often referred to as a swayback. What happens here is that whenever there's excessive abdominal girth, it puts weight in the front of the body, and so it causes the spine to kind of, the lower back to kind of cave it. I'll just show you a picture. So you can see here, like the spine has this excessive curve, and usually that's from excessive weight building up in the front, pulling on it, and that can be from pregnancy or obesity or anything like that. So generally treatment is going to be weight loss, exercise. They have some braces you can wear. Generally it'll resolve itself like after pregnancy. Then we have kyphosis. Kyphosis is the hunchback that you typically see with like older grannies, knitting or playing bridge at the retirement home. Frequently caused by osteoporosis or disc degeneration. And this is what that looks like. So the top of the spine starts hunching over. And here's a picture of like a typical granny from osteoporosis having that hunchback. Now here on the right, we have a young man who's developing kyphosis. This is not due to osteoporosis or degenerative discs, but rather ankylosing spondylitis, which is a disease we talked about in, let's see, what was it? Chapter 3, I believe, autoimmune disorders. So what's happening here is that his own self-antibodies are attacking the joints in his spine, and kyphosis is a result of that. So sometimes you can look at a disorder like kyphosis and have to figure out what's the cause, right? Is it osteoporosis? Is it degeneration just from wear and tear? Or is there an autoimmune component going on? So sometimes it can be hard to tell. But you can look at the patient, be like, okay, young man, this is actually one of those few autoimmune disorders that tend to affect men more than women. So ankylosing spondylitis frequently happens in younger men. Since it is an autoimmune disorder, there'll be more systemic manifestations like fever, malaise, elevated inflammation, kind of more of like a sick feeling because your body's literally attacking itself. Whereas with kyphosis, there won't be any of that since there's not an immune process going on. It's just old age happening. Then we've got scoliosis. This is where the spine curves laterally to the side instead of outwards or inwards. So it's crooked. Generally, one of the first ways to tell that you have scoliosis is one leg being longer than the other, or for women especially, if one bra strap needs to be tightened a lot more than the other. That's because of uneven shoulder lengths. They have various braces you can wear that might help treat these. Sometimes they do surgical intervention to fuse the vertebrae together. Yep, those are the 3 spinal disorders. Moving on to osteoarthritis, which we've talked a little bit about already as we talked about kyphosis. So osteoarthritis is a degenerative joint disease that results from the breakdown of cartilage over time. So symptoms of this: joint soreness, stiffness, aching, edema, pain, deformity. Usually, you know, when you have two bones that rub together, like let's say the elbow, for example, there's going to be cartilage on the ends of each bone, so like in the forearm and in the humerus, so that you don't have raw bone rubbing on each other. But over time, as this cartilage gets broken down, it'll just be the raw bone rubbing on each other. And that's when you start hearing that sound, that crepitation. You can hear crepitation. It's also called crepitus sometimes. It's like that crackling sound, like when you roll your ankles or your wrists, you hear that crackling noise. That's the raw bone rubbing on each other. It's common in the elderly, just because they've lived longer, they've used their joints longer. They frequently happen in the weight-bearing joints, like the hips and the knees, just because they receive most of the stress during our lives, holding up all the extra weight. So yeah, etiology is just with aging, progressive wear and tear. Diagnose this with CT scans, MRIs, X-rays, just any imaging to look at the ends of the bones and the soft tissue there. There's no cure. You can't like restore the cartilage once it's been damaged or broken down, but you can like prevent it as much as possible. You can reduce the inflammation from making it get worse, minimizing pain. If it gets bad enough, you have a joint replacement, like a knee replacement, hip replacement. So NSAIDs are standard ibuprofen. So lots of like old people tend to pop ibuprofen like it's candy, which, as we talked about in the digestive system, this is why elderly people are more at risk for stomach ulcers, because chronic NSAID use, right, is a risk factor for causing a stomach ulcer. Okay, so that's one of the questions, you know, you might want to ask somebody is like, you know, if they're complaining of stomach pain, you think they have an ulcer, like asking them about how much NSAID use are they using. It's like, do you have a bad knee or a bad hip? Are you taking ibuprofen all day? You know, just as a screening thing. Muscle relaxants also can help relieve some of the pain and stiffness. And then they also have intra-articular steroid injections. Intra-articular means into the joint, so they'll take steroids and instead of having to take it systemically and have systemic effects of the steroids, they'll just go straight into that joint and help with that inflammation. Here's a picture of a healthy joint on the left and one that's has osteoarthritis. You can see the development of bone spurs on the sides from the irritation of the raw bones rubbing on each other, and how the cartilage is starting to break down in the middle. So, all right, so let's compare the two different types of arthritis that we've now learned about so far. We've talked about rheumatoid arthritis, which was, again, in Chapter 3, autoimmune disease. And now we've talked about osteoarthritis. So the difference is, again, similar to with kyphosis and ankylosing spondylitis, is that rheumatoid arthritis is an autoimmune disorder. So you've got autoantibodies that are attacking the joints systemically, right? So most of the time with osteoarthritis, it's not every single joint that hurts, right? It's like, oh, I have a bad left knee, or I have a bad right hip, right? And you just have like one or two things that are like, you know, hurt that from overuse. But with rheumatoid arthritis, it's like indiscriminate, right? It's like it's all the joints are being affected, also accompanied with malaise and fever, because it is, again, an immune response. You're going to have that sickly feeling, whereas you're not going to have that with osteoarthritis. So that's another way to kind of tell the difference between, oh, is this joint hurting because I have rheumatoid or because it's osteoarthritis? Age is also a factor as well. Young people can have rheumatoid arthritis. It's not impossible, but it's just more rare for a young person to have osteoarthritis. All right, bursitis. Bursitis is inflammation of the bursa. The bursa is a fluid-filled sac around the joints. The purpose of them is similar to cartilage. They're meant to like just reduce the friction of the bones rubbing on each other, because rubbing bone on bone is not comfortable. Symptoms of this, it's just whenever you move the joint, it's just gonna be painful. You might have some reduced range of motion as well, just because of the pain and inflammation. Some swelling and edema also. These are most common in the shoulder, elbow, knee, and hip, just joints that are like frequently used, especially like in sports, like overuse, right? You move your shoulder a lot more than you move like your pinky toe, for example. Causes of this, it could be an infection. You could have had a cut over a joint, got some weird bacteria in there, or you could have had an infection that get into the bloodstream and then it drop off the infection in the joint. You could also just be caused by excessive friction from overuse of the joint or some kind of trauma that happened, like maybe got in a car accident or injured. Who knows? Anyways, diagnostic-wise, an MRI, that's going to be the most useful. MRIs are better for looking at soft tissues, like muscles, tendons, ligaments, cartilage, or anything that's not hard like a bone. An MRI is better at picking up those finer details, where x-rays are better at looking at bones, or not super great at picking up the softer tissues. You can also do a aspiration, which is where you stick a needle into the fluid and pull some out, and then you can analyze it under a microscope, see what's in there, see if there's any infective agents in there. Treatment-wise, it's going to be rest, let it heal, heat and immobilization, just giving it a chance to, to rest and recover. NSAIDs for inflammation, steroid injections as well. If there is an infection, obviously antibiotics are going to be given. You can also drain the infected fluid out to help speed up the healing process, clean everything out. Yeah, this is what the bursa looks like. You can see it's like this fluid sac. This is the shoulder in between the bones, just to provide a little cushion and support. And then when it's really inflamed, you can imagine any movement of that shoulder is going to push on it and cause pain. All right, now we're on osteomyelitis. Osteomyelitis is a very serious bone infection. So like this infection is actually inside the bone, okay? Somehow the infection, bacteria, whatever, traveled through the bloodstream, got into the bone. There are blood vessels that go to the bone. So with the symptoms, it's going to be obviously swelling and inflammation, redness and pain, tenderness over the bone that's affected, maybe even chills and fever depending on how widely infected it gets. Malaise, something also called a periosteal abscess. An abscess is like a collection of pus in an area, kind of like a really big pimple in a way. And that can form on the bone. That's what periosteal means. Sometimes it can get so bad where it causes the bone to actually fracture. So that's not good. Etiology is most commonly caused by Staphylococcus aureus. This is what we know of as a staph infection. You may have heard of a staph infection before. That's the most common bacteria. How does this get into the bone, right? Well, it could happen if you're in surgery. Unfortunately, surgeries are supposed to be sterile. They're supposed to, disinfect everything, but sometimes mistakes happen and germs are transmitted. Also happen in trauma. So like if you get stabbed and, the knife hits the bone, or if you're in a car accident, you get deeply cut, or like if you have one of those bone fractures where the bone sticks out of the skin, anything like that. How do you diagnose this? You can do a blood culture. Now, what's the purpose of a culture? So a blood culture, when you take a blood sample and then you put it, in a petri dish or something to see what bacteria will grow, right? There should be no bacteria in your bloodstream. If there is, it'll grow, and then you can analyze the bacteria that grow under a microscope and see what it is. So you're like, oh, okay, yep, this is a Staphylococcus bacteria, or no, this is something else, so that you know which antibiotics to give, right? Like all bacteria are different, and they're not all susceptible to the same drugs. So like a staph infection will be treated with one type of antibiotic, whereas something else would be treated with something else. So you need to know what the bacteria is before you can give an antibiotic. Imaging, MRI, CT, X-ray to kind of see what's going on. Especially if there's an abscess forming, you don't really know if this is an abscess from infection, or this could be a bone tumor that's growing, or the bone is growing and there's like this lump forming. Maybe it's Paget's disease, which we haven't talked about yet, but we will in a couple of slides. So you don't know, like when you see that there's like a lump growing on the bone, you don't know what it is, and so you assess it. You don't know if it's an abscess, you don't know if it's a tumor, or when we'll talk about in Paget's disease when we get to it. There will, obviously, since it is an inflammatory process, there will also be an elevated ESR and elevated white blood cells because there's a serious infection that you're trying to fight. Treatment-wise, antibiotics, of course. Depending on how bad it is, they might even surgically remove parts of the infected bone. And this is just kind of a picture of what an infection inside the bone might look like. I couldn't find any like actual real pictures of real bones, so this is what we got. All right, so now we're in gout. Gout is an interesting condition, pretty common, but it's also just interesting. So how it works is there are molecules and compounds called purines that are in certain foods. Okay, they tend to be common in things like shellfish, what else? I think also certain alcoholic beverages like beer and various liquors have purines that can make it worse. But anyways, the purines in the food, when your body breaks them down, they turn them into uric acid. And then uric acid is normally just excreted out of the body by the kidneys. The kidneys work by filtering the blood, right? So that's one of the main jobs of the kidneys, to filter everything in the bloodstream and then to excrete it out of the body, like get rid of all the toxic waste in the form of urine, okay? Now, with gout, the problem is that these elevated uric acid levels from the ingestion of purines leads to formation of uric acid crystals that stay in the bloodstream and then land in the joints and cause pain. And the joint that's most commonly affected for whatever reason is the big toe. They collect there. They're like these little crystals that cause serious pain, excruciating pain. They come and go. The attacks come and go. So it kind of just depends on the current level of uric acid in the body. So when these people reduce the amount of food that they eat that contain purines, they don't have any attacks, right? Because the purines don't get broken down into uric acid. But when they do, like, you know, maybe they go eat a bunch of seafood and have several beers, their body's going to break down those purines, and then their uric acid levels are going to spike. Then those uric acid is going to turn into crystals that lodge in those joints and cause pain. And this doesn't happen to everyone. It's kind of unclear exactly why some people have this and others don't. They theorize that there's like some enzyme that maybe these people lack that can help break things down properly. But yeah, so if you have it, it's unfortunate. You just got to watch what you eat. So let's see. When you have high levels of uric acid in the blood, that condition is called hyperuricemia. Okay, hyper meaning too much, uric being for uric acid, and emia always means in the bloodstream, right? So hyperuricemia. Okay, diagnosis. How do you diagnose this? Well, you just do blood tests looking for the uric acid levels. They usually will be elevated, right? Most people, like, their kidneys just excrete it and it's no problem, but for some reason their uric acid levels are staying high and not getting excreted by the kidneys. You can also do an aspiration of that joint, especially of that big toe, to see if you can find any urate crystals in that fluid from that joint. Treatment-wise, low purine diet. They also have found that increasing dairy for some reason helps to combat this for whatever reason. So an excuse to eat all the cheese you want. NSAIDs help with the pain. Corticosteroids help with inflammation. There's also a category of drugs specifically for gout called anti-gout medications, and colchicine is one of those specifically, but there'll be more info on that on the drug sheets Here's a picture of what those uric acid crystals look like in that big toe. And here's just a little diagram of the different stages of gout. So, you know, the uric acid buildup in the bloodstream. This person's starting to have a uric acid attack. They'll start having pain and stiffness in that toe. And then when the advanced stage, they harden into the bone. They cause bone erosion and erosion of the cartilage. So this is one of those things where it's like you want to get it taken care of before it causes permanent damage and disability to that toe. All right, so Paget's disease. We mentioned it, and now here we are. Paget's disease is a chronic bone disorder. It's not something that comes and goes. It's kind of a insidious effect, which means it like happens slowly that you might not even notice, but it causes the bones to be weakened and deformed. Okay, so what's happening here is that, you know, we talked about the osteoblasts and the osteoclasts. What's happening with Paget's disease is that the osteoblasts, for whatever reason, are like on overdrive, and they're creating new bone faster than the osteoclasts can break them down. So what happens is that the bones start getting deformed, right? Because they're creating all of this new growth and material, and it's just forming like these lumps that shouldn't be there. So that's why I said, like, you don't know if it could be a tumor, you don't know if it's an abscess, you don't know if it's Paget's disease, if you just see like a weird lump or you know, mass on a bone, right? Symptoms of this, like I said, could be asymptomatic. You might not even realize it's happening. You could have some bone pain over the area. You might have some fractures because over time, like, the deformed bones aren't going to be as strong as bones that are shaped properly, right? So fractures are likely. Hypercalcemia could happen, just because the bones are being affected, so calcium just being high in the bloodstream. And renal calculi. Renal calculi happen, or that's what kidney stones, the medical term for kidney stones. Anytime there's high levels of calcium in the bloodstream, the calcium can clog up the kidneys that are trying to filter the blood and cause kidney stones. So diagnostic-wise, there are 2 blood tests that'll come back for people with Paget's disease. In the bloodstream, there will be elevated alkaline phosphatase, and in the urinalysis, will show elevated hydroxyproline. Treatment-wise, if the person doesn't have any problematic symptoms, then just leave it be. There's no treatment. If they do have symptoms or it's problematic, then they can have analgesics for the pain, anti-inflammatories, calcitonin injections. So remember we talked about calcitonin and parathyroid hormone. Calcitonin takes calcium from the bloodstream and puts it into the bones, okay? So since one of the symptoms is hypercalcemia, that means there's too much calcium in the bloodstream. So calcitonin will help take that calcium from the bloodstream and put it into the bones, which will help make the bones stronger, right? And with Paget's disease, their bones are deformed and weak, so that would help. It might be counterintuitive to take a high calcium diet since they have hypercalcemia, but if you're going to be giving the calcitonin injections, it is just going to help all of it go to the bones. Same with vitamin D. It helps to absorb that calcium so the bones can actually use it. And here's a picture of just like what that excessive bone growth information looks like. Like they're just producing all these bone cells and they're just kind of latching on and creating this lump on that humerus. All right, I just want to spend some time real quick talking about the action of calcitonin, just to make sure we understand, and comparing it to insulin, another hormone. So I'm just going to read this here. We know that insulin is a hormone secreted by the pancreas, okay? And insulin is the vehicle, so to speak, that transports glucose from the bloodstream and takes it into the cells, because they need to use that for fuel, like to keep the cells going. They're little factories and they need fuel, right? So in the same way, calcitonin is a hormone that serves as the vehicle to transport calcium. Okay, so the calcium gets transported from the bloodstream into the bones. Insulin transports glucose from the bloodstream to the cells. Okay, without insulin, glucose can't go anywhere. It just remains in the bloodstream, causing hyperglycemia, too much glucose in the blood. If we don't have calcitonin, then calcium remains in the blood. It also can't go anywhere. This causes hypercalcemia, too much calcium in the blood. Okay. The problem with having too much glucose in the bloodstream is that it increases thirst, which we call polydipsia. Have you ever eaten like a box of donuts and then felt like, oh gosh, I need to drink a gallon of water? It's just kind of like a compensatory reaction to kind of dilute all that sugar. Also, increased urine output, which we call polyuria, to try and get that sugar out, because like we don't want a lot of sugar in the bloodstream. It's not good. Like there's a happy level. When it goes beyond that, we run into problems. Okay, when we have too much calcium in the bloodstream, as mentioned before, this can cause the kidneys to get clogged up by trying to filter all the stuff out. The calcium deposits can form kidney stones, which we call renal calculi. And if you remember from chapter 4, when we were talking about endocrine disorders, we talked about other symptoms with hypo and hypercalcemia. There was the Trousseau sign, which was the arm curving in, and the Chvostek sign, where the face is twitching, because calcium affects the muscles. Okay, so just seeing how all of this fits together, like all the body systems work together. All right, next one is an interesting one. This is a new one. Most people don't know about. This one is called Marfan syndrome. This is a genetic disease, so it's inherited from your parents in the DNA. How I remember this one is I think of the word Martian, because it sounds like Marfan, and you'll see why. So the symptoms of Marfan syndrome is having abnormally long extremities, so really tall, very slender, with very long and narrow fingers, so we're kind of picturing like an alien creature. They tend to have visual problems because of the shape of their lens and things like that. They also may be prone to scoliosis as well. But the main issue with Marfan syndrome is that they tend to have heart and vessel abnormalities that can cause aneurysm. And we talked about aneurysm in the circulatory chapter. An aneurysm is when one of the blood vessels ruptures, and so you start bleeding out internally. The problem with this syndrome is that a lot of the times it goes undiagnosed, right? It's just kind of an odd conglomeration of random symptoms, and unless you have like a really good primary care doctor who's able to put all the pieces together, it can often go undiagnosed and undetected until one day someone has an aneurysm and with catastrophic consequences. The other thing about this syndrome is that the severity can vary. Some people might have a really bad case. Some people might have just like a mild case. So like, there's not like a textbook picture of what someone with Marfan syndrome looks like, which also contributes to making it harder to diagnose. Etiology-wise, like I said, it's a genetic disorder. It's autosomal dominant. There's recessive and dominant traits, right? So dominant only needs one set of genes, whereas the recessive, you need two in order to pass on that trait. So if a mom and a dad have a kid and one of the parents has Marfan syndrome, that child has 50% chance of inheriting the disorder. Diagnostic wise, usually based on the symptoms, right? So like they kind of check the boxes of all the different things that make up Marfan syndrome. What they can do, what's important to do, I should say, is that frequent checkups with like a cardiovascular doctor to do echocardiograms to inspect the heart and the vessels, see how wide the aorta is getting, to see if there's any weakened areas, just to make sure that they're not like imminently at risk for an aneurysm. Because that's the main deadly factor with Marfan syndrome. The rest of it, the long fingers, long legs, scoliosis are more cosmetic problems, but the aneurysm is the catastrophic thing that's trying to be avoided. With that, treatment-wise, controlling blood pressure is going to be really important, because high blood pressure puts a lot of pressure on those vessels. And if those vessels are weakened due to genetics, right, then that's going to make it more likely to have an aneurysm. So it's like blowing up a balloon with or a water balloon with more and more fluid. Eventually, like, it's gonna so much pressure that it ruptures, right? It's the same idea with blood in a vessel. If they do find places that are weakened or likely to have an aneurysm, they can do surgery to replace those, to take the weakened part out and reinforce it. So I'm about to show you some pictures. These are extreme cases of Marfan syndrome, so not everyone looks like this. But here you can see like the long, slender fingers, the long, slender feet, and the legs being really long. This is why I said I remember Martian, to help me remember. Here's a picture of a woman with the really long legs, the really long arms. You can see how long the arms are in comparison to like the rest of her body. Her arms like come down to her knees. And then you can see the scoliosis as well. All right, so osteoporosis. Osteoporosis is a bone condition characterized by the loss of bone density. So this is usually age-related, your bones over time getting weaker. Symptoms of this, it's kind of similar to some of the other ones where there's not really many symptoms until something happens. So you don't really notice that your bones are getting weaker until one day you do something simple, like bend over and pick up, I don't know, a bag, and it causes you to fracture your arm bone, right? So something that shouldn't cause a fracture will. So they call those spontaneous fractures. The spine is common place for spontaneous fractures because it holds a lot of weight, right? Your spine holds up your whole body. Also loss of height. So you know those old ladies who start to shrink as they get older? That's a symptom of osteoporosis. People that are more likely to get osteoporosis are short women, short-statured women of either white or Asian descent who are the light-skinned, right? So like Asians and Caucasians tend to have like a fairer skin, but also like being blonde, blue-eyed, that also contributes as well. And smoking. Smoking is a big one. Smoking definitely leads to osteoporosis. It's not good. Immobility as well. Remember we talked about how being immobile and sedentary promotes osteoclast activity. Alcohol and being post-menopause, just because of the hormones interplay. And then long-term steroid use. This is one of the issues with taking steroids long-term, is that they can cause osteoporosis. So what's happening here is that it's the opposite of Paget's disease, where the osteoblasts are going crazy and the osteoclasts can't keep up. In this case, it's the opposite. So the osteoclasts are breaking down bone faster than the osteoblasts can build it up. Okay. Diagnostic-wise, you can do blood tests looking at levels of calcium, vitamin D, phosphorus, all that stuff, hormones, how their calcitonin levels doing, how the parathyroid levels doing. The main one, though, is going to be a bone density scan. It's called the DEXA scan. This just measures how dense the bones are. So, like, are they really strong, or are they, like, getting really weak and porous, which is where we get osteoporosis. To treat this, vitamin D and calcium, also phosphorus supplements as well, are going to help if they're, if it is due to like a vitamin deficiency. There's also calcitonin nasal spray, which can help as well. So all those supplements you're taking to help put them back into the bones. There's also a special drug class called bisphosphonates, which I remember because it kind of sounds like the word phosphorus. It reminds me about bones. What these do is they actually inhibit osteoclasts. So they tell the osteoclast to, hey, calm down. Like, you're not helping, actually. You're making things worse. So, and those will be on the drug list as well. And here's just a picture of what extra porous bones look like in the osteoporosis. So obviously there's more air than there is like bone matrix, right? So they're going to be much weaker and more likely to fracture. All right, so now we got osteomalacia / rickets. These are actually the same condition. It's just the name is different depending on the age. So in children, we call it rickets, and in adults, we call it osteomalacia. Symptoms of this, well, basically what it is that your bones are going to be extra soft, so they haven't gotten hardened, and from a lack of vitamin D and calcium, so that they can't harden, right? The reason why the bones are hard are because of those minerals. So if you're not getting enough of those minerals, for whatever reason, maybe, living in poverty and not having access to good nutrition or whatever, or not having any good sunlight or whatever. Yeah. So symptoms of this can be general fatigue. The bones are going to be tender and painful, backaches, difficulty standing up, just because standing on soft bones, like it's like standing on a wet spaghetti noodle, right? Like they just bend, which causes actually bowed legs and fractures. Here's a picture of like the legs bowing out just because they're not hard enough to maintain the weight. Like I said, lack of vitamin D or sunlight, which makes it impossible to absorb calcium and phosphorus into the bones. This is why they do early screening of babies now for their vitamin D levels, just to make sure that they're getting enough so that they can prevent the development of rickets in children, so they don't have to end up having, these problems for their whole life just because they had a vitamin deficiency, right? Especially babies, a lot of them aren't going to be outside very much, or they're dependent on their mom for nutrition. And if they're, breastfeeding and maybe the mom isn't getting enough vitamin D, then the baby isn't going to get enough. So screening for this early helps to prevent, lifelong complications. To diagnose it, you just, looking at, the assessment of the bones, maybe some imaging, bone scans, blood work to look at all the different calcium, phosphorus, vitamin D levels. A biopsy could also possibly help as well, just to rule out any other conditions as to what's going on. And then treatment is obvious, fix the problem. So the problem was not enough vitamin D and calcium and phosphorus, so supplementation, very easy. Also calcitonin as well to help put that stuff where it needs to go, into the bones. All right, so next we've got hallux valgus. Okay, this is the medical term for a bunion. Okay, a bunion is one of the, you've probably seen it, like a big kind of lump next to the big toe on the inner side, which we call the first metatarsophalangeal joint. Symptoms of this is just going to be inflammation and pain on that toe. The great toe is going to start angling in towards the midline of the body. This tends to happen with people that have flat feet, or if they're wearing shoes that are too tight that kind of push the toes in. And heels. Wearing heels is a huge risk factor for developing bunions. Diagnosis is just going to be to rule out things like gout, right? So pain in the big toe. Pain in the big toe could be gout. It could be a bunion, right? So kind of trying to rule out what it is so you know how to treat it. X-ray can help visualize the bone, see what's going on. There are braces that you can wear for the toe to pull it back to the center, which work pretty well. You just, this is what it looks like. So the toe just starts progressively going more this way, and this right here is what we call the bunion, like this part that sticks out. And this brace, you can see like it has this stiff kind of metal insert, and you wrap the toe around it, so it like forces it back to this direction. Anyway, with this, it can get so severe actually that the big toe actually goes like underneath the toe next to it. Obviously that makes walking difficult. What else? Anti-inflammatory drugs, steroid injections into the joint, wear looser shoes. They can even do surgery to take the bunion part off that sticks out, which is just called a bunionectomy, because this part is really tender and sore, and like is going to rub when you wear shoes, so it can be very uncomfortable. All right, so next we got hallux rigidus, okay? This is also related to the big toe, but the big toe is stiff. It has reduced range of motion because of a loss of cartilage. So generally this happens from repeated injury and trauma to the toe. Like maybe you're, you know, play sports and you jammed your big toe many times or stubbed your big toe. Whatever. Underlying arthritis, wear and tear on that toe, whatever. So it's just going to be painful to move, not being able to move your big toe as much anymore, stiff and swollen. X-rays will help determine that. Just a physical assessment, determining the range of motion. Anti-inflammatories will help decrease inflammation, obviously. PT and rehab to help get some of that range of motion back. Sometimes bone spurs can develop just from the bone just rubbing on each other and causing irritation. They can do a prosthetic. They can take out the old joint and put a new one in. And this is kind of like an example. So normally you should be able to bend your toe, your big toe up pretty good. With hallux rigidus, you can see that the range of motion is severely limited with lots of pain. All right, so now we have a strain and a sprain. You've probably heard of these terms, maybe used interchangeably, but they're actually referring to different things. So a strain is actually tear to a tendon or a muscle. So you could tear a muscle, and that's called a strain, or you could tear a tendon. A sprain is a tear to a ligament. Okay, so what's the difference between a tendon and a ligament? Well, let's show you a picture. A tendon is that dense, fibrous connective tissue that connects muscle to a bone. So you can see the calf here is being connected to the bone there. And then a ligament is what holds bones together. So bone to bone, just keeping the bone stabilized. All right, so with symptoms, pain and weakness, edema, ecchymosis, which is bruising, and the swelling can be really bad. I sprained, both my ankles umpteen times, but the first time I sprained one of my ankles, it got so big, it was almost the size of, well, let's see, probably like a softball. It was really bad. I couldn't put a shoe on, couldn't hardly get a sock on. So it was so bad, they thought maybe it was broken, so I got x-rays just to rule out any fractures, but it was all just soft tissue, so tearing probably a bunch of different tendons and ligaments in my ankle. This generally happens from some kind of acute trauma, like sports, really common. You roll your ankle wrong. Mine happened from doing tumbling in gymnastics, landing on my foot wrong. It can happen from chronic overuse, but just generally, that's more common in maybe people who are that older. Diagnostics, x-rays can, like I said, rule out fractures. MRIs can look at the soft tissues. For treatment, you may have heard the acronym RICE, rest, ice, compression, elevation, to help speed up the healing process. NSAIDs and anti-inflammatories to keep the swelling down. And then possible surgery depending how bad it is. So if a tendon or ligament is torn all the way through, sometimes it doesn't heal because the two ends can't find themselves and reattach. So sometimes in surgery they can help bring the two ends together so they can heal properly. And then this is just a picture again. Another drink of water here. Okay. Adhesive capsulitis. This is also known as frozen shoulder. This is just reduced range of motion of the shoulder due to inflammation of the capsule. The capsule is what the shoulder kind of sits in to help keep it lubricated and move better. So symptoms: very stiff, painful shoulder, may disrupt sleep, especially if you're a side sleeper, right? You sleep on your side, especially if you're sleeping on the affected shoulder, cause pain. Etiology, what's happening here is the capsule is inflamed, either from some kind of trauma, some kind of injury, some kind of infection, whatever, what have you. Anyways, what ends up happening is that scar tissue starts to develop in there, which starts to reduce the range of motion because all these adhesions are keeping it from being able to move freely. And for whatever reason, diabetes is a risk factor. Just a little like tip, diabetes is generally a risk factor for almost everything, so just keeping that in mind. Diagnostic wise, you can do obviously a physical assessment, be like, oh, yep, it's tender and can't move that much. X-rays can rule out any fracture. Even though it hurts, it's necessary to keep that shoulder moving just to prevent permanent disability, right? So people tend to keep it still because it hurts a lot, but that actually makes it worse because that scar tissue and adhesions develop and like reduce the range of motion even further. So it's important to keep that shoulder moving with the steroid injections to maybe help with that. PT and rehab are probably also going to be necessary. You can see here just what regular and may look like and what an inflamed capsule would look like. All right, shin splints. Shin splints are a pretty common phenomenon. It's inflammation of the periosteum in the lower leg. So the periosteum is the membrane surrounding the bone, just like pericarditis is, sorry, the pericardium is the membrane surrounding the heart, and pericarditis is the inflammation, right? The meninges is the membrane surrounding the brain, and meningitis is the inflammation of that. So that's what we're looking at here. So the symptoms of this is going to be some inflammation, maybe some edema, pain along the tibia, which is the shin bone. It gets worse with exercise, but improves with rest, okay? This is really common for people that maybe are starting out in the first few weeks of a new exercise program. So it's just a matter of like their body's not used to it, right? Especially if it's like high impact, like running. I did track in high school on the sprint side, and every year, like the first couple weeks, I would have awful shin splints, and it was just terrible. It's just that your legs aren't accustomed to that high impact all the time, and so they kind of have to just get used to it. Typically happens in both legs, which is what we call bilateral. Something else can also cause this if you have something called excessive foot pronation, and I'll show you a picture here. So this is what like a neutral standing position looks like. This over here, when your ankle rolls out, like kind of like when you sprain your ankle, like from rolling your ankle outwards, that's called supination. The other direction where your ankles like kind of collapse inwards is called pronation, right? So if you have pronated feet, like when you stand or walk and they kind of like collapse inwards, that can cause shin splints just because of the pulling. You're like stressing out the calf muscles, which pull on that bone. So one of the ways you can help fix that is from like wearing arch supports to like get your foot back up to the neutral position. And that's just what the periosteum looks like. It's the membrane surrounding the bone. But anyways, diagnostic, you might actually see tiny fractures on the tibia if you do bone imaging, just because of that high impact. Treatment-wise, just resting, not overdoing it, waiting to get used to it. It generally goes away after a while. NSAIDs, stretching can help, loosen up those calf muscles. Like I said, you can use one of those orthotic inserts for the foot to prevent that pronation. Again, this is just what I talked about, the overusing of the legs causing stress on the muscles. All right, coming up towards the end here. Plantar fasciitis. I don't know if anyone's ever experienced this, like that strong, like pain in the bottom of the foot, like maybe the first thing in the morning when you get out of bed and maybe need to go to the bathroom, and it's like you take a step and it's like, this searing pain in like the arch of your foot. This is plantar fasciitis. Okay, there is some muscle fascia on the bottom of the foot here that attaches to the heel. And when this gets inflamed, it's just very painful, obviously. It is common in athletes, especially runners, but it doesn't have to be. My dad had a bad case of this, and I promise you, is not an athlete or runner. But yeah, it's the pain on the bottom of the foot, usually worse in the morning or after a period of resting until you walk on it a bit and stretch it out. It can be from overuse, so, like I said, athletes or runners, but also people that maybe just walk a lot, on their feet a lot. So that could be nurses or, I don't know, another job that requires standing or anything that puts strain on that tissue of that foot. Just a physical assessment is enough to diagnose it, just like patient experience and kind of just pressing on the bottom of the foot causing pain. Rest and anti-inflammatories and arch support for the feet are what can help this condition. All right, I think this is the last one. I think. Yep. So ganglion cyst. A ganglion cyst is benign, so it's not cancerous. It is a fluid-filled sac that grows, very common in the wrist. They can happen other places. My mom had one, like, actually on the inside of her wrist instead of the back side of her wrist, and they sometimes can happen on the fingers as well, but for whatever reason, they're very common on the back of the wrist. I actually had one. I just had one removed this past November. Finally hit my healthcare deductible for the first time ever after giving birth to my daughter. Surprise, having a baby is expensive. So I was like, well, everything beyond this is free, so I might as well get it done now. But yeah, I got it done just because I've had it for like 20 years, and it doesn't hurt. Like, pressing on it didn't hurt, but it would hurt when I would do things that would require me to bend my wrist. So, like, doing push-ups, putting weight on my hand in, like, a bent position, or, like, a handstand, would hurt my wrist a lot. And so I'd have to wear, like, a brace. And I was like, this is dumb. I hate this. Sometimes people's just go away spontaneously. Mine did not. It was just there for, like I said, like 20 years. So they also have... There's other ways that you can get rid of them. Like, people can take a book and smack them really hard to burst them. I really wasn't going to be in favor of that, so I was like, let's just get it removed, which is called a ganglionectomy. If you look down at the treatment, they can't, like I said, rupture cysts with pressure. You can press on it, aspirate the fluid out with a needle, or the ganglionectomy, which is what I had done, where they just cut the skin open, take the cyst out. No one really knows exactly why people get these. It can be caused by repetitive, like, injuries to the wrist, but, like, not that I can recall, I don't think I've ever had any of those, but, that's pretty much it. This is what it looks like. There's, like, a little grape formed on the back of the wrist, and it's just forms, just a benign fluid sac. But that is it for the musculoskeletal system. Hope you enjoyed. Let me know if you have any questions.